Good evening all to the 128th session of the weekly Huddle. I am your host, Anoop Agrawal, and joining me today is my friend and co-host Praneeth Palamari. We both are cardiologists working at Kim's Hospital. As most of you know that the Huddle is an unscripted audience level interaction where we address common clinical scenarios that we encounter in our daily practice. Typically, we take a case and we discuss around that particular case in terms of how we would manage it in a most pragmatic as well as scientific way possible. Once a while, we do talk about a particular topic like what we did last time, where we discussed about the ongoing COVID pandemic, which was less of a case-based discussion, but more of a scenario-based discussion. But today we are back with a case-based discussion, and to help us navigate through our topic for today, I'm joined by a senior urologist at Kim's Hospital, Dr. Arvind Panda. He was there with us a few weeks back where we discussed sterile pyuria with him. Arvind sir, welcome.
Yes, thank you so much. Very kind of you to have me here.
All right, so I'll go with the case, and it is customary for me to ask my co-host Praneeth to give his initial impression, and then if there is any comments from the audience, we will take that before we move to Arvind sir for his expert comments. So, case for today is a 52-year-old female. She had an old history of seronegative arthropathy, essentially non-specific arthralgias that she had, which was evaluated multiple times. And she had not been on any major medications on a chronic level. She basically attended her son's wedding that was about 2 weeks back, and claimed that she had been quite busy in arranging all of it. But now she had been having this 2 days history of right loin pain, which was paroxysmal and spasmodic in character. It would come unannounced. It would last for a few seconds to sometimes a few minutes, crampy in nature. It was sometimes associated with vomiting episodes, but there were no any fever, no dysuria, or any other abdominal discomfort, as in constipation, diarrhea, or whatnot. So she didn't report any other symptom, just this pain, which was going on for about 2 weeks, 2 days, excuse me. She was seen at an outside hospital where an abdominal ultrasound was done that showed 8 mm renal stone on the right side, which was thought to be located at the pelvic ileal system of the right kidney. And the ultrasound also mentioned mild hydronephrosis without any signs of pyelonephritis. She did undergo a routine lab assessment, most of which were normal. A urine examination was done, that also was not significant. Now, this all was done in a different city. So I am only assessing the reports, and I'm providing a second opinion for this patient. So after this ultrasound, a CT KUB was done, which also confirmed an 8 mm stone. And the CT mentioned 1073 Hounsfield unit, which again, I have no idea how to interpret that. But because that was the finding on the CT scan, I'm mentioning it. CT also confirmed the location of the kidney stone being in the pelvic ileal system. And it did confirm very mild hydronephrosis without any signs of pyelonephritis. In fact, there was another tiny calculus in the renal parenchyma somewhere around the apex, for which the measurements were not given, most likely because it was a very tiny stone. Now, as a cardiologist, why am I talking about kidney stone, or why am I providing second opinion? Because I believe in our practice, in our clinical scenario, renal stones are one of the common etiologies of abdominal pain, particularly in younger patient subset, but sometimes it is seen in our patient group that we take care of, particularly in their 40s and 50s. And many of the times, we as a cardiologist or general physicians or whatnot, they are often the first one to evaluate that pain syndrome. And many of the times, the patient would like to get our opinion before they head on to urologist for their expert opinion. So that is where I was providing basically a second opinion, or in a way traffic policing, and telling the patient or guiding the patient which way to go or what to do. And for me to be able to do that job properly, I thought it was reasonable for me to at least discuss, or at least know some of the very basic aspects of managing or analyzing kidney stones. So I have put in a few topics here, a few points that I would like to discuss, and then I'll ask Arvind sir to lead us with each of those topics. So Praneeth, I'll start with you. The questions that I have listed in the discussion are based upon this clinical picture. Are there any additional investigations that you would like to do before you say that now I have done a reasonable initial evaluation? Remember, we are talking about an abdominal pain, and we have an empiric diagnosis of renal stone. So the question here that's going to come is, do we need to do investigations to look for other differentials? Or if we believe that the pain is because of kidney stones, are we done with our initial workup for kidney stone, or do we need to do some other assessment as well? Second, conservative versus surgical approach in terms of when would we think that these are the patients who should be sent to urologist for a surgical evaluation, or when we can make a reasonable decision saying that this patient can very well be managed conservatively with hydration, and only when the pain doesn't subside that we send them for urology for surgical intervention. Are these decisions, are these clinical decisions which we feel comfortable taking as a non-urologist? And then the role of non-invasive modalities like shockwave, extracorporeal shockwave, lithotripsy, or any other newer therapy option. I believe Dr. Panda will be able to guide us through that. And strategies to prevent recurrence, particularly with reference to our cardiovascular patient subset. Is there something that we can do to prevent recurrence? Also, we'll talk about this particular case, but I would like to emphasize a little bit on the kind of patient subset that we get, which are typically diabetic or hypertensive, slightly on the higher side in terms of age, may or may not have established cardiovascular disease. So how we can manage in preventing recurrence of those patients. So Praneeth, if this patient was to come to you to get your initial opinion before you advise this patient to seek a urologist opinion, how would you approach this?
Yeah, good evening, everyone. So the history that was given is suggestive of a renal colic. So obviously the first differential is a renal colic, and the direction of investigations will be to look for the same, starting from clinical examination to loin pain to ultrasound, X-ray, and CT scan. So this patient has already underwent CT scan, which in my opinion is the gold standard in diagnosing the renal stones. Now, when we talk about renal stones, in my understanding, it all depends on whether it is obstructing or not, and whether it is, what is the size of the issue. This patient has symptoms, which means those stones are probably the culprit. And equally, there is an obstruction in the to the flow of urine, as evidenced by dilatation of the pelvic calyceal system. So this is producing an obstruction, and that stone, which kind of got dislodged from the pelvic calyceal system and getting stuck, is the cause for the renal colic in this patient. So for me, the diagnosis is made, and I do not need any further evaluation to be made. So almost the history and these investigation findings go together. They are concurrent. Now, talking about obstruction, you mentioned about two stones. One is obstructing, and another probably is not obstructing. So the focus will be on this obstructing stone. Obstruction can occur depending on the size. In my opinion, something which is less than 1 centimeter or maybe less than 0.5 centimeters are something which usually do not obstruct, but there is a gray zone between 5 to 10, and something which is more than 10 mm or 1 centimeter, most of the time they may obstruct. So depending on the obstruction, we need to make a decision. And this patient, because the patient is symptomatic and also there is an evidence of obstruction, that obstruction needs to be relieved, and preferably the patient will be requiring a degestenting. So I would be sending this patient for a urology opinion. Regarding the non-obstructive stone, probably because it is not causing an issue, that can be managed conservatively, which is an incidental finding, and I believe it is not causing any harm. So that can be ignored and or kept a close watch on onto the patient. Now, how to treat? First important thing, in my opinion, is to relieve the obstruction and then take care of the stone. How to take care of the stone? Again, probably depending on the location and the size, the decision will be made. This is kind of out of my knowledge, so I will be learning from Dr. Arvind about this thing. Now, preventing a recurrence, again, I believe it is a bit controversial, but I'm equally keen to know the emphasis on hydration to prevent renal stone is common, but I believe it is not universal, or at least it is controversial, which I would like to know. And also other modes of treatment in the form of barley water or other things, other traditional methods which people do use. Equally, I'm keen to learn about them. So I believe if you can maintain adequate hydration, and again, adequate is probably a very vague term. How to define an adequate hydration is something which is a bit vague, but this is what I can think which will prevent. Rest, I'm equally keen to know from today's discussion.
So Praneeth, thank you for that initial starting point. And I believe this hydration part, it is particularly relevant for us because a lot of our patients, they are fluid restricted in terms of how much they can drink if they have any evidence of heart failure. So it is going to be a little bit challenging for our population to blanket recommend them hydration. Before I start my discussion with Dr. Arvind, I'm inviting any of the attendees, if they have any opinion or any suggestions about this particular case or how they would go about, please feel free to unmute yourself and share your thoughts. And I will also invite Shankar sir to give his opinion. Shankar sir, you are a general physician, and I'm pretty sure a lot of the times you are the first doctor who is encountering these kind of symptoms. You'll be making clinical decision or diagnosing these patients with nephrolithiasis. If a patient like this were to come to you, how would you handle, or you would directly hand it over to urologist? Shankar sir.
Good evening to all. This is an interesting case. Patient has got this 8 millimeter size renal stone in the pelviuretral junction, and the density, it is also denser because the Huntsfield units are more than 1,000. So it is a dense calculus at the pelviuretral junction. So such cases, we go by, usually we refer it to urologist only, needs surgical intervention. We leave it to urologist, and they will do this URS, that is a ureteroscopic intervention, so that the pelviuretral junctional stone will be removed. But if it is not denser, and if it is more than 15 millimeters, then we would have gone for PCNL. Or if it is less denser, then ESWL also is an option. But here, in this case, 8 millimeter size stone, denser in the pelviuretral junction, usually the urologists also, they go for the URS, ureteroscopic, or it can be tackled even by the PCNL also. This is my opinion regarding the surgical intervention. It needs a surgical intervention by the urologist because there are signs of obstruction there. So regarding the preventive measures and all later we'll discuss later.
Thank you, Shankar sir. One of the question which is asked, and I'll directly address it to Dr. Panda as he's giving his opinion. The question which is raised here is the role of trial of tamsulosin and steroid in patients whose stone is smaller than 10 millimeters. So, Arvind sir,
Sir.
I will ask your opinion. So you got the case history. If this patient were to be referred to you, please walk us through your thought process. How would you, what you call, tackle the individual points that I have mentioned, which I will list it out again for you. Any additional investigation as a part of initial evaluation? How would you decide conservative versus interventional approach? How do you choose non-invasive modality like shockwave versus what Shankar sir was mentioning, urethroskopy, and your version of how to prevent recurrence? That prevention we'll also discuss with Shankar sir once we are done with the initial impression. Arvind sir, the floor is yours.
Sir, thank you so much for having me. It's quite an honor. Firstly, I just want one clarification. This stone is in the PCS or it is at the pelvic junction?
Sir, PCS or pelvic junction? You asked a very difficult question. As you walk us through, I will give you
Yes.
the CT
So,
report.
sir, always the 8 mm stone in the PCS. It's a non-obstructing because it can be in the pelvic calyceal system, in the lower calyx, in the middle calyx, or in the upper calyx. These stones typically do not cause obstruction, and if there is no obstruction, there is no pain. Obstruction is typically due to the distension of the renal capsule, or sometimes the ureteric sheath, and that is what causes pain. That is what causes referred pain in renal and ureteric colic. So if there is a stone, the stone will be silent if it is not causing obstruction. That is my point number one. And in such patients, particularly who have some seronegative arthritis, it is entirely possible to have a nerve root compression, which can cause very similar type of pain. So it is, for us, it is very important to delineate that yes, this there may be a stone, but is this stone responsible for these symptoms? If it is, we need to treat. If it is a non-obstructive stone, we need to give all the options to the patient that this is yes, there is a stone here, but it may or may not be responsible for your symptoms. Secondly,
Sir,
in this, as you have, hello?
Sir, I will interrupt you just for a second. I'll just read through the CT report,
Yes.
which is in front of me. So it says, right kidney normal in size, position, and outline, approximately 8 millimeter size calculus with attenuation of 1073 Hounsfield unit is noted in the right renal pelvis. So
Right.
they only
Renal
mention
pelvis,
right.
yes, then probably causing intermittent obstruction. If
Okay.
it is 8 mm calculus in the renal pelvis, it's probably causing intermittent obstruction and probably responsible for these symptoms, no doubt about it. So,
Okay.
so then secondly, about what can we do about it? If it is a symptom, if it's a stone causing symptomatic obstruction there, obviously it needs to be treated. Now, Dr. Praneeth already has mentioned about the stones can pass out. Now, the general rule of the thumb is if a stone is less than 5 mm or even 6 mm in size, the chances of it passing out are very high. Up to 70 to 90% of stones less than 5 mm or to 6 mm will pass out if in the correct circumstances. When I say correct circumstances, I mean normal anatomy, no narrowing or stricture, and in a patient whose kidney is functioning well. So sometimes there may be a narrowing or maybe a stricture and it may not pass out. Stones more than 7 mm, there is a lesser chance of passing out. The chances drop to around 40%. More than 7 mm, again, it drops even further. So it's 8 mm stone in the pelvis causing intermittent obstruction. Chances of passing out are less. It is very likely to get stuck somewhere in the ureter. In the ureter, there are 3 areas which are actually quite narrow. One is the pelvic junction. That is first area. The second area is when the ureter goes over the iliac vessels. That is the second area of narrowing. And the third and the most narrow area is the vesico-ureteral junction, the VUJ. So any of these 3 areas, the stone can get stuck, and that's where it usually gets stuck. So this is at the first area at the pelvic junction itself. Coming to the point, how can we treat it? Yes, This is a 1074, 1073 HU, which means it's a moderately dense stone. Can ESWL break the stone? First, we look at non-invasive approaches. Yes, ESWL can break the stone in the pelvis, certainly, particularly if it is a good machine. The point about good machine has to be reiterated, because most of the ESWL machines that come are not very good. We're talking of good, we're either talking of Siemens Lithostar, or we're talking of the Dornier Delta series. These machines come upwards of 3.5 to 6 crores. So if there is such a machine available, then it is definitely justifiable to attempt breaking a renal stone with that machine. And a 1074 8 mm calculus will almost 100%, 98 to 100% break. It's with the cheaper ESWL machines, shock lithotripsy machine, that which do not actually fragment the stone, and so shock lithotripsy in general gets a bad name. And this shock lithotripsy can actually be done without any anesthesia in adult patients, and it doesn't even require stenting. But there's a caveat here, particularly in your patients who are usually on antiplatelet drugs, and sometimes they are on anticoagulants. So I might ask them to stop antiplatelets or anticoagulation for a few days before we do a shock lithotripsy in these patients. Coming to the second modality is since this is almost a renal stone, we have to use something called a flexible URS in this. So we have to do retrograde intrarenal surgery. Now, retrograde intrarenal surgery is when we pass a flexible ureteroscope from the urethra into the bladder, then into the ureter and up to the kidney, and we fragment the stone with a laser. The problems that can happen is sometimes the ureter can be very narrow. Though in females, in almost 80% of females, we'll be able to do a primary RIRS in a small subgroup, and in about 50% of males, a primary RIRS is not possible because the sheath which we put, the axial sheath which we put into the patient does not go in an undilated ureter. In these patients, we have to do a pre-stenting first, put a stent, and this stent over a week's time will dilate the ureter, and after a week to 10 days, we can do a RIRS in these patients. We can actually put the flexible scope into the kidney and then catch the stone with a basket, or even without a basket, fragment it with a laser to very fine dust. And then the stent is again placed, and the stent is kept typically for about 3 weeks, and then removed. By that time, all the fragments have usually passed out in the urine. And about PCNL, not for such a small stone like 8 mm, but for larger stones, as sir was saying, more than 15 mm or even more than 1 centimeter, if it is a 1 to 1.2 centimeter stone, and that expertise is available for mini PCNL, that's definitely an option. So for one thing is about clearing all the stones. Second thing, as rightfully mentioned, can we clear out all the stones and then prevent recurrence? For the prevention of recurrence, there are certain broad guidelines. And one of the things that we need to do, yes, as we said, increase. That is the only thing that has been proved to certainly reduce recurrence is increasing the amount of fluid intake. How much? That the person must pass at least 2 liters of urine. 2 liters of urine per day, and the urine must be clear. So the amount of fluid intake can be adjusted according to the climate and where the person is staying. In a cold climate, even 2.5 liters of water can produce 2 liters of urine. In warmer climate, this may be difficult, so you may need to increase the water accordingly. As you have rightly pointed out, in your patient, particularly patient with LVF, it will be difficult to give so much fluid. So the other things that we often say is, one, there are certain things which sort of inhibit stone formation, particularly citrates. So we need to tell them to take more citrus fruits, particularly oranges, mosambi, and lemons. And in fact, I encourage my patients to take these fruits regularly. Regularly every day. I tell them you should squeeze a piece of lemon into into your drinking water whenever you drink. Third is reduce the amount of salt they are taking. I think we'll be on the same page on this about reducing the amount of salt. Fourth is reduce the amount of animal protein. I tell them animal protein once a week is fine. You don't have to give it up, but once a week, not every day. Then we tell them to reduce. Fifth is we tell them to reduce weight, because the more weight they have, more likely are they to have hyperoxaluria and hypercalciuria, which are two most common causes of increased stone burden. And we also tell them after this to have plenty of green leafy vegetables and fiber and fruits up to 5 helpings a day, as long as the patient is not diabetic. And they are encouraged to have juices as long as they do it without sugar or without salt. Sugar to cut down weight, and salt, of course, as we have said, we don't want more salt because that also causes hypercalciuria. So these are the general guidelines that we tell every patient who has stones. And there is a stone clinic effect, actually. Even people who form stones, if then they come to visit the doctor and they advise properly, there is certain evidence that the number of stone incidences in this population keeps coming down. But stone formation is a very complex thing. It's not a single gene phenomenon, because you can see there are many people taking the same food in the same house, and only one of them will get stones and the rest don't get stones. And there are many myths that you should not take bananas, you should not take tomatoes. There is nothing like that. In bananas are absolutely harmless. Tomatoes in moderation don't cause any problems. And one final point is the patient should take a normal amount of calcium. It should be a normal calciumic diet. If you take a hypocalcemic diet and reduce calcium completely, what happens is more oxalate is absorbed by the intestine. If you take calcium, this calcium binds to oxalate and forms calcium oxalate, which cannot be absorbed. So if the more oxalate is absorbed, there's more chance of stone formation. So these are some of the things which I tell my patients. And it's very important that stone formers should follow up at least once a year, and with at least an ultrasound, so we know what's happening in the kidney. Any questions, I'll be very happy to take.
Thank you so much, sir, for that comprehensive review. I have gathered few questions which I want to ask you, but at the same time, I am also inviting my attendees, if any one of them have any questions or comments. Shankar sir, you have something to add before I start?
The distal ureteral stones, in that we resort to medical expulsion therapy, but most of the times, 80 to 90% of the times, we are successful when the distal ureteral stones, 4 centimeters from the uretrovesical junction. So in that, as earlier, when we were students, we used to give forced diuresis and IV fluids and the Lasix, but nowadays that is contraindicated. It is counterproductive also. It exacerbates pain. But when you give a combination of alpha blockers, tamsulosin, 0.4 milligrams orally daily, and NSAIDs, Brufen 600 milligrams 3 times daily. But here, congestive heart failure patient, so here it is contraindicated. And with or without, if there is no urinary tract infection, then we can give a short course of low dose corticosteroids. Example, prednisolone 10 milligrams orally for 5 to 10 days. We give this treatment, this expulsive therapy. We give, so we wait for 4 weeks. If it doesn't pass the urine, especially the less than 5 millimeter stones, they don't need any specific line of treatment. They will pass away spontaneously. But 5 to 10 millimeter size stones, especially around 7 millimeters, then we follow this medical expulsive therapy, and we wait for 4 weeks. If it doesn't pass spontaneously, then we will refer it to urologist. This is regarding the medical expulsion therapy from our physician side, the medical side. We resort to. Then coming to the 10 commandments for the prevention of renal caliculi or the urolithiasis or the nephrolithiasis. Sara is already
Sir,
covered.
before you go to that, I have this one to ask you. Nowadays, one company is promoting this Tamfil DS, that is tamsulosin and deflazacort, I think 30 milligram combination as a single use for stone expulsion, medical therapy. What is your opinion about it? As a
Sir,
physician and the urologist also, I would like to know. What are their opinions?
so this is
Shankar
Dr.
sir,
Arvind, madam.
yeah.
This is
Arvind sir,
absolutely no justification for giving single dose tamsulosin and deflazacort. There are 3 drugs which have been used actually for medical expulsive therapy. One is alpha blockers. Any type of alpha blockers you can use. Tamsulosin is one which has been most extensively studied. Second is nifedipine has been tried. Third is, of course, steroids. Now, what we have found is the addition of steroids has a very little benefit, slight benefit over, but not really significant. So most of the urologists do not use steroids. So I don't personally use steroids at all. So I don't think it makes a great difference. Most of the stones which have to come out on their own. And alpha blockers, particularly, they work because alpha receptors are more common, as Dr. Shankar so rightly pointed out, in the distal ureter. So only stones which are in the distal ureter, mid to distal. When I say mid, I mean below the sacroiliac joint. May have some benefit with alpha blockers. Anyway, how much benefit? There are certain RCTs which show no benefit, certain which show benefit. So the amount, so there's actually heterogeneity among trials, and I really do not know how much benefit that cause. But alpha blockers can be used. Certainly, they are not much harm. Steroids, I personally do not use. And thinking of a fixed dose, single combination, I cannot think of anything more abominable. These pharmaceutical companies will make any sort of combination and use it until it is banned.
Shankar sir, your comments about this?
Regarding earlier, we were carried away by the impression that increased calcium intake is associated with the stone formation. Now, Dr. Panda has already alluded to. So now it is otherwise. The low calcium intake paradoxically leads to already mentioned oxalate absorption and consequently hyperoxaluria and the stone formation. So dietary calcium should not be restricted. It can be liberally allowed to up to 1000 to 1200 milligrams per day. But regarding the calcium supplements, but there is some mild risk is associated with the calcium supplements in the stone formation. So if the calcium supplements are advised medically, then along with the meals, these calcium supplements should be given. And in that case, the dietary calcium and the supplemental calcium should not exceed beyond 2000 milligrams per day. So calcium supplements should be given along with the meals. This is a point to be noted regarding the calcium intake. And regarding these calcium oxalate stones, the oxalate containing foods like baked potatoes with the skin, the sweet potatoes, the French fries, almonds, cashews, they are all contain high oxalate containing foods. They should be avoided. The 7th point. Then 8th one is a purine. Purine should be restricted in the diet, like red meat, legumes, beer, wine, and others. So, and we should alkaline the urine, as I already mentioned, that is citrus fruits and the lemonade and all. So, and one more important thing is the drugs also, they cause the nephrolithiasis. Especially, we give topiramate in as a anti-epileptic drug and anti-migraine therapy also. We give topiramate and jonisamide, that is another anti-convulsive therapy, anticonvulsant, and Diamox, the astazolamide, we regularly use in many conditions. So Indinavir, earlier, more than 25, 30 years ago, as antiretroviral therapy, we used to give Indinavir, but because of the pill burden and because of the urolithiasis, that was discontinued. And the diuretics, laxatives, so many Even antibiotics also, they do cause some stone formation. So medication, we should take medication history, and what are the drugs to be avoided also should be mentioned to the patient who comes with a recurrent history of stones passage. These are the 10 commandments regarding the prevention of stone formation. Thank you, one and all.
Thank you so much, sir. If I may request you that if you could list those 10 commandments, or if you have a table or something which you could share it on the WhatsApp group, so our group members can keep it handy for them. Anybody else has got any comments or questions before I start reading through the questions which have been put on the chat box? Or if you have any question, you can just put it in chat box, and I will make sure I discuss it with Arvind sir. So Arvind sir, if you could unmute yourself, I have got a series of questions for you, which I will pick up from the chat box, and I would like your attention onto this. So the alpha blocker that we have mentioned already, I just have one follow-up question on that. We mentioned tamsulosin. The regular dose that we use is 0.4 milligrams once a day, typically at night time. Is that the dose that we use for medical expulsion also?
Yes, yes. The same dose. More than that, it will.
And how long?
More than that, it can.
Arvind sir, your voice is breaking a little bit. If you could get onto a more
I think
stable.
0.4 is perfect.
Mhm.
0.4 is perfect. I don't think more than that we need to give.
And
Hello?
for how long you give before you say it has failed?
Sir, typically, sir, I am going to give it for about 2 to 3 weeks. I give following up the patient. The patient must not have a rising creatinine, intractable pain, because these are all indications for intervention.
And when you say intractable pain, what is the kind of duration or frequency you are talking about? Somebody having pain every day, will that be classified as intractable?
Hello.
Yeah. Arvind sir, what do you classify as
So yeah,
intractable?
so intractable pain is pain not responding to analgesia, and or the patient has to take more than 4 days of continuous analgesia. I will say intractable pain. So
Okay.
sometimes even after we give a lot of analgesia, the patient says, I'm still having a lot of pain, I can't bear it. Then it's an indication for intervention. Secondly, another indication would be having a rising creatinine or having an infection, fever with chills or rising counts. That would be another indication to intervene. You must also keep in mind patients who are diabetic or otherwise immunosuppressed. These patients who are obstructed may land up in problems. So generally, I tell my patients, I tell them, just keep in touch. If there's a problem, if there's any red flag, you need to get back to us.
Sir, you mentioned about infection as one of the indication of intervention. We always worry that if there is any infection in urinary tract, and if you are doing any kind of procedure, we always fear that we can create this ascending problem. What is your thought on that?
Sir, two things I want to say. One thing, if the patient has ureteric colic, I don't give antibiotics along with analgesic. That I certainly don't do. Because if there's obstruction and there is infection, antibiotics is not going to help immediately. We have to drain the obstructed system. If there is no infection, I always get a urine culture before intervening for stone, at least a CUE or urine microscopic. If that is not showing any great pus cells, I would go ahead with adequate antibiotic prophylaxis. And if you are doing this in the correct patient with adequate prophylaxis, infection is generally not a problem as long as we have kept our instrumentation sterile. And we put a stent normally for most urinary calculus, that is to drain. And before removing the stent, I think it is a good idea to get a urine culture and an X-ray cavity to check that there are no residual fragments if it's a radiopaque stone, and the urine culture if possible to make sure that there is no infection before you pull out the stent.
Thank you, sir. The other question which is asked is stone analysis or so-called stone biopsy or stone pathology.
Yeah, that's very interesting. That's a very interesting topic. For single stones, individual patients, I do not do analysis. But for a child, a recurrent stone former or bilateral stones, I would do analysis. Because most of the time, 95% of the time when we analyze, we're going to get calcium oxalate phosphate. It is not going to change our management. What I do for all stone patients is a basic metabolic workup. I do a calcium, I do a phosphorus, I do a uric acid, I do an albumin. This is something I do for all patients. Serum calcium, serum phosphorus, phosphate, uric acid, and albumin I do for all patients, because I want to know. So I have sometimes you catch a slightly elevated PTH or elevated uric acid, which needs to be treated. Uric acid stones are typically radiolucent, but they can form a nidus on which other stones can form.
Sir, when you do the cystoscopy, just
Also cause
looking at this,
opaque stone.
when you do cystoscopy, just looking at the stone, can you tell what kind of stone it is?
Sir, when we break the stone, if it's a soft, very soft stone, it's more likely to be radiolucent. And but if it's a very hard stone, then it's more likely to be an oxalate stone or a phosphate stone. Phosphate stones are more common. Oxalate stones are typically spiky. So you can say, okay, typically, but all of them will contain calcium, oxalate, and phosphate. So when you do a stone analysis, you'll get all three of these. And second thing is, stone analysis has to be done in a very specialized lab. Such labs are not easily available. And it doesn't change your management. You will still tell, drink more water, take more citrate, the same thing, and reduce animal protein. The same things you're going to tell this again. So stone analysis makes sense in a particular subset of patients, not for everybody. But a basic metabolic workup should be done for everybody. As for doing a complete, a complete comprehensive workup, including urine assay, that should only be done after you have completely cleared the stone, because even if a small bit of a stone passes out, sometimes you can get a very abnormal value. So that is indicated in sort of recurrent stone formers, and so you check for hypercalciuria, hyperoxaluria, all those things. But that is only for a very limited subset.
And sir, there is a table which is shared in the group which talks about, in patients with recurrent stone formation, there are certain urinary parameters that you can use it as a target to minimize recurrent stone formation. It has to do with urine volume, pH, creatinine clearance, excreted calcium, sodium, uric acid, oxalate. All these, are these more theoretical, or this
Sir, it's very difficult. They are more theoretical, sir. Very difficult to get this. As I've already said, obviously that will be most recurrent stone formers have underlying metabolic abnormality, but to actually get these is very difficult. That's one of the reasons why we don't really have large scale RCTs on stone. Very difficult. Even in the setting of an RCT, it is difficult. Forget about the common general life and general lifestyle. So I would not look at that very closely. I would tell them general principles, but I've already told, and I would insist that they follow the general principles. It's very difficult actually to and secondly, measurement of urine calcium, urine oxalate, all that are quite difficult. And the lab variable, I think there was significant interlab variation. And again, we have to clear, as I've already said, we have to clear all the stones from all the systems. Not even one small particle must be there when you start doing all this. All these things is very difficult to achieve, and it's not worth it.
Sir, one question that came is, if you could please expand what is ESWL, PCNL, RIRS, just very briefly, so that we know your language.
Sir, ESWL is actually a registered trademark of the Dornier company. What we should use is shockwave lithotripsy. ESWL stands for extracorporeal shockwave lithotripsy. When the first HMG 300 lithotripter came out in Germany in the early 80s, they called it ESWL, extracorporeal shockwave, outside the body, extracorporeal shockwave lithotripsy. And that is, they sort of registered the trademark. After that, the general term to be used is SWL, or shockwave lithotripsy. PCNL is percutaneous nephrolithotripsy, where we actually make a hole outside and we make a hole in the kidney, reach that stone and break it. The third thing is the RIRS, retrograde intrarenal surgery, where we go from below with a flexible scope through the urethra, into the bladder, into the ureter, and the kidney. We do use a flexible scope for that. That's called retrograde intrarenal surgery. Finally, URS is for the stone in the ureter, mid and lower ureter, sometimes the upper ureter also, where we use a rigid scope, not a flexible scope. We go there, see it, and we break it. Now coming to methods of breaking stones, the energy source, one is extracorporeal energy source, as we already said, shockwave lithotripsy. Other is we use a ballistic lithoclast. It's a very cheap instrument, around 50 to 70,000 rupees from Indian manufacturers, where a sort of a ballistic energy is used to break that stone. Third, of course, is a laser, which is very common nowadays. And there are many types of lasers. One is, of course, the holmium laser. Other is the thulium fiber laser. Both of these can be used to fragment the stone. The advantage is they cause less retropulsion than the ballistic lithoclast. So even upper ureteric stone we can break without it sort of migrating into the kidney.
Sir, why can't we use laser from outside? Like maybe a stupid question, but we can't use laser from outside.
Basically, we'll have to. These are contact lasers. These are contact lasers. They have to be close to the stone. And if you're going to use from outside, they have to burn through all the tissue. They have to burn through skin, soft tissue, kidneys, and then reach. Because that is how they work. The energy gets absorbed there, and then there is then if there is something called a chromophore for each laser. For instance, for holmium laser, it is water. So it heats up that water, and that expands and explodes, causing the stone to fragment. So it has to be close contact with the stone, and we have to be careful when using laser. It's not a panacea. If you start using a laser very in an impacted stone in the ureter, we can burn the ureter and we can cause a ureteral stricture. In fact, that is the most common cause of ureteral strictures we are seeing today. Inappropriately done URS with a laser. Sometimes in an impacted stone. So we have to be careful with every modern modality. There comes a lot of caveats.
Sir, why can't you simply just take a basket or something and just grab the stone and drag it out?
Yes. Sir, the Dormia basket was a time-honored method. Used to be used even when we didn't have a ureteroscope. A basket used to be passed up. Stone was grasped under fluoroscopy and pulled out. The problem is the stone sometimes is bigger than the ureter. And when we pull it out with a basket just like that, the chance that even the ureter will come out with it. It can cause a total, avulsion of the ureter. So we have for small stones, we do pass a basket through a ureteroscope. Under vision, we take the stone out along with the basket. But for larger stones, you have to break them. Otherwise, they will damage the ureter as they're coming out. Because the basket will pull out and you can't even release the stone from the basket once it gets jammed in the ureteric mucosa.
Sir, if I heard you correctly, you mentioned you would like to stop dual antiplatelet before you do shockwave lithotripsy. Is that correct, and why?
I would prefer to do that, sir, because one of the complications of shockwave lithotripsy is having a perinephric or a subcapsular hematoma. I would like to reduce.
Your voice keeps breaking, sir. Arvind, sir, now we have lost you completely.
Hello. Yeah.
Yeah. Now we can hear you.
Yeah, I would like to stop it for 5-7 days, sir, because one of the complications is perinephric or a subcapsular hematoma. So I'd like to stop.
So that has a practical implication, because to my understanding, shockwave lithotripsy is not a one session, right? You do periodic.
Yeah, we do 3 sessions, sir. We do at least 3 sessions, and we ramp the frequency and the shock energy depending on where the stone is. For the kidney, we'll use higher frequency and higher energy. For the ureter, we'll use lower frequency and lower energy because it's more susceptible to damage. And I would stop antiplatelet certainly. So maybe, sir, we can do a complete. So maybe for about 3 weeks, you'll need to stop.
Right. So it's not just a 5-day stoppage; it's a 3 week stoppage.
Actually, sir, it depends. Because small stones like 8 mm stones, one session may be enough to break that stone. Okay. And the second point is when those fragments come down, they may cause some bleeding. So maybe for a small stone, 2 weeks. For slightly larger, 3 weeks. It's nothing hard and fast. We have to play it by the ear. We see how many days we stop. But yes, I would not restart. At least I would not restart dual antiplatelets for these patients. No.
Praneeth, your other 2 questions about calcium vitamin D supplementation, I think that has been answered. And then the red flags, I think that also has been partly answered by Arvind sir and Shankar sir, about very early age or recurrent stones or soft stones. So soft stones would be uric acid stones, right? Right, Arvind sir?
So uric acid is one. There can be ammonium urate stones, and there are many other. There are some other. And another thing is to worried about is something like infection stones. This is
Okay.
not in this. Infection stones are typically true white stones, and magnesium, ammonium, phosphate stones, and these typically they are found in presence of infection, and this is the most dangerous type of stones. I feel they can cause loss of kidney very quickly. So, but these are not very common. I mean, we are not very common to have infection stones in patients, but we do see them from time to time.
Sir, how common it is to see, let's say I'm evaluating a patient of abdominal pain and I'm evaluating for renal stones. Let's say that's one of my differential diagnoses. How common it is to see urine analysis with no red blood cells?
So very, not very common, but in around 20% of cases, you won't see microscopic hematuria, particularly if the stone is sitting there, it's not moving around. In patients of colic, almost 90-100%, you will see microscopic hematuria. But if the stone is sitting in one calyx and not moving around, you may not see.
Almost 20%.
So this microscopic hematuria is typically seen when the stone moves down, and it sort of hits that mucosa and it sort of impacts the mucosa. It comes down, abrades the mucosa. There you'll see hematuria. You can see microscopic hematuria. But sitting there silent somewhere, no, you may not see. But if you're
Okay.
but investigating for colic, you will see invariably.
Okay. So one last question I have, and then if any attendees have any other questions, please post it in the group. Sir, my last question to you is, you talked about stricture, whether stricture can interfere with the medical propulsion and all those things. Is there a way to diagnose preemptively whether you are dealing with stricture or not? Are there any investigation, or you can only do it when you do
Yes.
cystoscopy?
No, sir. See, we are talking of ureteral strictures here. Classically and ideally, when we investigate for stone disease, we should do a imaging that involves contrast. So if you do a CT, we should do a CT urogram. If you do an IVP, which is a time-honored method, we should do it. We are doing it with a contrast. So that shows us many things. It shows us where the stone is. It gives us a roadmap of the entire pelvic system. It also shows us if there is an obstruction. But increasingly, the contrast imaging is being left out, and people are doing non-contrast CT scan to diagnose stone disease. While non-contrast CT scan is, as Dr. Praneeth said, a gold standard for diagnosing stones, it cannot tell us anything about the pelvic system or the ureter. So I feel that is so. Then so it's not ideal. And when we see hydronephrosis or a dilated ureter, I feel we should switch over to a contrast imaging immediately once we see that finding on the non-contrast scan. So that would tell us whether there's a stricture there or what is the. So whenever I see a very small stone causing a lot of pain and not passing out for a long time, I would always order a contrast. If the patient says I have no problem waiting, and I don't mind coming in 2 days showing you a contrast imaging, I would prescribe a contrast if the creatinine is normal. But now patients want immediate diagnosis within 10 minutes. So non-contrast, I think most practitioners will go with a non-contrast CT scan.
And sir, just out of curiosity, how would you differentiate a ureteric peristalsis with stricture if you do contrast?
So we are looking at a multiple series of images, not one image. So in an IVP, it is very easy because the same you take an X-ray many times. So I mean 4-5 times. So each time you look at that area whether there's a stricture or there's a peristaltic. In a CT, it is slightly difficult because it's only a single cut they take. But even in that, if you are seeing good contrast below, and there is no thickening of the wall, and no significant hold up, we can roughly say, yeah, this looks okay. The wall is not thickened. There is good contrast drainage below. Probably that's the sort of peristaltic way.
Perfect. Thank you so much, sir. That was all the questions that I had. And
Thank you. Thank you so much.
Shankar sir, you have anything really quick?
Only a simple urinary pH estimation will tell us what type of stone we are dealing with. If the persistent urinary pH is less than 5.5, acidic, then it suggests only uric acid stone. At the same time, it is not a hard and fast rule, but most of the times in the clinical practice, we go by this. And persistent urinary pH, if it is more than 7.2, it suggests either struvite stone, as Dr. Panda alluded to, that infection related, or it may be a calcium phosphate stone. If it is a normal urinary pH, most of the times it is a calcium oxalate stone. And one more point in the imaging also, when we order for the non-contrast CT, the low dose ionizing radiation protocol we administer, and especially in the prone position. This has to be especially mentioned because the distal ureteral stones at the vesico-ureteral junction, or whether it has passed into the bladder or not. So sometimes it will be difficult in the supine position. That's why we order for a prone position non-contrast CT. And at the same time, we'll know the density of the stone also by Hunsfield units with this non-contrast CT low dose ionizing protocol. And one more thing, that the medical condition, not medical condition, we regularly come across a few cases of nephrocalcinosis, because both the kidneys are studded with the multiple stones. Thousands of stones will be there in both the kidneys. So in that case, we order for serum calcium and 24-hour urinary calcium and intact parathormone. Looking at these parameters, if it is a hypercalcemic and hypercalciuria and increased parathormone, we say that it is a primary hyperparathyroidism we are dealing with. And if there is a hypercalcemia and if there is a hypocalciuria, there is a low urinary calcium and the normal parathormone, it is a familial hypocalciuric hypercalcemia, FSH. So, and one more condition is also there, that is a distal tubular acidosis. Because recently we have come across one case of nephrocalcinosis. We have investigated, so it has turned out to be hyperparathyroid. Then we have gone for the scanning, isotope scan. Then we have to rule out any adenoma or cancer of the parathyroid, or even if there are no adenoma or carcinoma, if it is a primary hyperparathyroidism, then we have to remove the parathyroid gland. If there is hypercalciuria, we treat with long-acting diuretics like chlorothalidone or indapamide, not with the hydrochlorothiazide. If it is used, it has to be given twice daily. Thank you.
Thank you so much, sir. Your prone positioning is quite interesting. Arvind, sir, are we doing prone positioning CT? Is that something which we routinely do or recommend? Arvind, sir, if you can hear me.
Please tell me. Hello?
Sir, yes, sir.
Yeah, please tell me.
Sir, prone positioning CT KUB.
Yeah, prone positioning is very useful if we are actually planning to see the ureter in full thing, or if we are planning PCNL. Because if you are doing PCNL, you are sometimes surprised by the retrorenal colon. You want to see that exact anatomy if you can do prone positioning. So instead of doing a supine positioning where the position of the colon may be different, you go for a prone positioning where the colon and its relation with the kidney is clear. So it is of greatest useful. It is of great use. It is most useful when it is done when you are planning PCNL. Otherwise, not much.
So shouldn't we, whenever we order CT KUB, shouldn't we just order prone CT KUB for all patients?
That's not a problem. It's not a bad idea.
It's
actually not a bad idea, as long as it's not at all a bad, because it doesn't cause any harm and gives us some additional information.
Perfect. Thank you. Thank you so much, Arvind, sir.
Thank you so much.
Yeah, I will invite Somaraju sir for his opinion about today's discussion.
Thank you, Anoop, and Praneeth and everybody. It was a lot of learning experience for me. I just wanted to say a few things. In say in 80s and earlier and 90s, before all these emerging modalities were available, acute anuric renal failure, one of the important causes was kidney stones, and somebody can comment on it. And secondly, the we generally, as cardiologists, we have some prejudice against use of thyroid diuretics, but this is one area where thyroid-like diuretics like chlorothalidone may have some role to play. The third issue is a lot of people have a habit of regularly supplementing vitamin C. What is its effect on it? And somebody can comment on it actually. And then also somebody just brought in the idea of CT scan. The limitations of ultrasound, the limitations of other methods, we know. The low-dose CT, what is its role in these patients? Thank you.
Thank you so much, sir. Anybody else has any other questions? Arvind sir, if you can hear me, could you please address the role of vitamin C supplementation leading to more kidney stone formation? Shankar sir, any feedback on that? Vitamin C supplementation and kidney stones, more or less?
Vitamin C in large doses we give, it produces hyperoxaluria. So ultimately the stone formation will be there. So vitamin C also should be curtailed.
Thank you so much, sir. If nobody has any other questions, I'll ask Praneeth for his closing comments for today's discussion.
Dr. Anoop,
Yes, sir.
the role of low-dose CT.
Role of low-dose CT, yeah, that is also something I think Arvind sir probably stepped out. I think Shankar sir, you are mentioning about using low-dose CT, right?
Most of the times we order for the low dose CT only. That is a protocol in case of CT KUB, especially thin individuals. But in obese individuals, we have to go for standard dose or a high dose.
Okay, so I have to answer the question on the role of low dose and high dose vitamin C, particularly those with citric food, and also the role of low dose versus standard dose CT scan. Those are the two things which please watch out for the WhatsApp space. I will try my best to answer those two questions. Praneeth, your closing comments for today's discussion.
Yeah, no. So the stones which are troubling to the patient, producing pain, almost always suggest an obstruction, or else renal stone per se should not produce any pain. So any renal stone, if it is causing pain, it's a problem because of the stretch of the renal capsule, and it needs attention. We need to focus on identifying the reason and equally treatment. So stones which are smaller in size, less than 5-6 millimeters, may go away, but something which is more than them, less likely to go. So an opinion from urologist seems mandatory. And depending on the character or the type of the stone and location of the stone, the urologist will make a decision on how to get rid of that stone, either approaching from below upwards or from above downwards. And again, whether to remove it in toto, break it through lithotripsy or through laser. It's an expert field which has to be better dealt by the concerned specialist. Now, once we treat, we also need to prevent it from happening. So some surveillance with urologists is equally necessary, and trying to find a reason why the patient had stone in the first place, trying to find a triggering factor, maybe low calcium intake in the food, probably excessive vitamin C consumption, or dehydration or any other systemic condition which is causing, probably having one thought or doing some basic investigations to look the same is probably important. And the hydration, adequate hydration when possible, with a target of close to 2.5 liters of urine output a day, should be advisable for all of them who can do. But when there is contraindications, like patients who are having heart failure or kidney failure, we need to be mindful of that. And a few tips being the increase in intake of calcium supplements in the food, and increasing the citrates in the food, which can probably alkalize the urine and prevent stone formation, are the few tips in addition to the in general basic hygiene maintenance. So these are the conclusions which I could draw from today's discussion.
Thank you, Praneeth. Just before I close, I will tell you the thumb rule that I got during my MBBS. Sometimes you get some of these cheat sheets which get stuck to your brain. One of the cheat sheets that got stuck to my brain when I was doing my surgical rotation as an MBBS student was this thought process in kidney stone that, and if I can say it correctly, that the percentage chance of expelling the stone or passing the stone spontaneously is inversely related to the size, which we have quite understood. And a basic rule of thumb is a 10 millimeter will have a 0% chance, a 9 millimeter will have a 10% chance, and 8 millimeter will have 20% chance, and so on and so forth. So if we take that kind of thumb rule, then a 5 millimeter stone will have a 50% chance of expelling, or a 4 millimeter will have a 60%. So that was something which got stuck in my mind for the past 20 years or so. And that seems like a very good thumb rule after I listened to the discussion today, where all of us are of this opinion that 5 millimeter or smaller stones are likely to pass medically. So with this, I thank you all for attending today's session, and special thanks to Arvind sir for taking his time and helping us out with this topic. We will be back next week with another topic, and I will try my best to answer the two questions which remain unanswered. One is lemon and vitamin C, and the second is the CT protocol. If I can get some answer, or if I'll ask Arvind sir offline, and I'll share it on the WhatsApp group. Thank you all. Good night. We will see you next Wednesday.